I am Dr. Chiadi Ndumele. I am a cardiologist and an associate professor in the Department of Medicine at Johns Hopkins University.
And I'm Dr. Janani Rangaswami. And I'm a nephrologist. I'm a professor of medicine at the George Washington University School of Medicine. And then when you extend that stage 3 CKM to stage 4, which is patients with established cardiovascular disease, we look at phenotypes, including ASCVD, where we have also not just included coronary artery disease, but also peripheral arterial disease and stroke, heart failure, as well as atrial fibrillation, which clusters along with all these other cardiovascular disease phenotypes. And then we have further taken the next step to divide stage 4 further into patients with and without kidney failure. And it is mostly because patients with kidney failure obviously represent patients at probably the highest risk category, for these events and recurrent events and premature death, hospitalizations, and poor quality of life. But interestingly, when you look at the data in terms of intervening across several of these risk factors, they are somewhat different in those from patients who do not have kidney failure, especially in those on dialysis.
I think the point of this approach, this staging system here, as you've described and we've said a few times, is getting people earlier in the process, implementing preventive therapies earlier, so to really improve those outcomes, not get people when they've already had that heart attack or when they're just about to go on dialysis. And then within stage 4, the reason why the CKM syndrome approach includes individuals both at risk for cardiovascular disease and also with existing cardiovascular disease is because for those individuals with existing cardiovascular disease, when they have CKM syndrome factors that are going to be unique treatment considerations. We've seen that for individuals who have obesity and cardiovascular disease, we're going to be thinking about, addressing that as in ways both through lifestyle. There's now emerging data for pharmacotherapies. We know that this is something we need to be addressing. When we see diabetes, we need to be thinking about SGLT2 inhibitors and GLP-1 receptor agonists for cardioprotective reasons on top of the other aspects of diabetes care. And then, of course, that's the case for chronic kidney disease. And you've just highlighted the importance of those kidney protective therapies and hypertension. The other thing I want to point out is that in this population, we haven't talked as much about LDL, which is obviously a really important aspect of prevention. And we certainly relate how aggressive we are in terms of LDL lowering therapies to the absolute risk of the patient. The patients with CKM syndrome, particularly those with cardiovascular disease, but even those who haven't yet developed cardiovascular disease, are often amongst the highest risk individuals.